Norman, and this is my descriptive epidemiology presentation, and I'll be presenting on Ebola virus disease, one of the most severe and feared infectious diseases in the world. We'll examine its epidemiology, clinical characteristics, transmission, public health impact. So let's get started. The objective of this presentation are fourfold. First, we'll define Ebola virus disease and explain why it remains a critical global public health concern. The second thing, we'll analyze its epidemiological pattern using the descriptive framework of person, place, and time. Third, we'll examine the clinical characteristics of the disease, including how it progresses and how deadly it can be. And fourth, we will explore how the global public health community has responded to Ebola outbreaks, including vaccination efforts and ongoing challenges. Here's an overview of what we'll cover today. We'll move through the person, place, and time framework. Then look at the outbreak timeline and geographic spread through charts and tables. From there, we'll dive into the clinical characteristics of the disease and how it spreads, and how close with public health impact in summary, and also true and false questions. Each section is grounded in peer-reviewed sources and public health data. Descriptive epidemiology asks three core questions. Who is affected? Where does the disease occur? And when does it happen? When it comes to a person, Ebola does not discriminate by age or gender. Anyone can be affected. However, certain groups face significantly high risk. Healthcare workers are among the most vulnerable because of the repeated exposure to affected patients and bodily fluids, especially when protective equipment is limited. Family caregivers tend to get sick from relatives that are also at high risk. Additionally, traditional burial practices, which in some West African communities involve washing or touching the deceased, have been a major driver of this transmission of Ebola. The place, Ebola outbreaks have occurred almost exclusively in sub-Saharan Africa, particularly in the Democratic Republic of Congo, Guinea, Liberia, and Sierra Leone. These regions often have limited healthcare infrastructure, and it makes early detection and containment extremely difficult because of that. Outbreak typically begins in rural areas, either near wildlife habitats, but can spread to cities rapidly. This chart shows the number of confirmed cases in major Ebola outbreaks from 1976, when the virus was first identified in the Democratic Republic of Congo, through 2022. As you can see, most outbreaks were relatively contained in the hundreds of cases. However, in 2014 to 2016, West Africa outbreak stands in dramatic contrast. It resulted in 28,616 confirmed cases and over 11,310 deaths, making it by far the largest Ebola outbreak in history. So it spread across Guinea, Sierra Leone, and Liberia, and even reached the United States and Europe through international travel. The 2018 to 2020 Democratic Republic of Congo outbreak was the second largest, with 3,481 cases. This was the first major outbreak to occur alongside an active vaccine campaign, which helped limit its spread. Looking at the key statistics on the right, on this chart, a case fatality rate of up to 90%, an incubation period 2 to 21 days, and nearly 900 healthcare workers infected in the 2014 through 2016 outbreak. It's clear why Ebola is classified as a public health emergency of international concern. This slide shows the geographic distribution of Ebola outbreaks, satisfying the spatial requirements of this for this assignment that I have. The table summarizes the countries that most heavily affected. The demographic of Republic of Congo was exposed with the most outbreaks over time, with over 9,000 cumulative cases. However, by sheer volume, the West African countries, Guinea, Liberia, and Sierra Leone account for the majority of Ebola cases due to the 2014-2016 epidemic. The pie chart on the right breaks this down by region. West Africa accounts for approximately 52% of all cases, Central Africa for about 40%, and East Africa, including Uganda and South Sudan, for about 8%. A critical public health observation here is that the relationship between geography and health infrastructure, rural settings with limited access to hospitals, clean water, trained healthcare workers are consistently where outbreaks start, and they're spread the most rapidly. The 2014-2016 outbreak demonstrated that even when an outbreak reaches an urban center like Monrovia or Freetown, it becomes much harder to contain. Ebola virus disease presents in 3 progressive stages, and the speed of that progression is one of the most alarming aspects of this disease. In the early stage, typically days 1 through 5, patients experience fever, fatigue, headache, muscle pain, and sore throat. These symptoms are nonspecific. They look a lot like malaria or the flu. So this makes early diagnosis extremely challenging because it's one of the reasons why Ebola can spread before it's detected. As the disease enters into the progressive stage around day 5 through 10, patients develop vomiting, diarrhea, a characteristic rash, and impaired kidney and liver function. At this point, the patient is highly infectious. The advanced stage from days 7 through 14 is where the disease becomes most life-threatening. Patients may experience internal and external bleeding through not always that way, but sometimes. Multi-organ failure and septic shock can occur, and this often leads to death. The key statistics here tells a sobering story. The fact that fatality rate can reach up to 90% in settings without adequate treatment. The 2 to 21 day incubation window makes tracking contacts especially difficult. And because early symptoms mimic common illnesses, patients may not be isolated quickly enough to prevent the further spread of Ebola, of the virus. Understanding how Ebola spreads is essentially the public health response. It's essential for public health response. This diagram shows the transmission chain starting with an infected animal, usually a fruit, bat, or a primate, which serves as a natural reservoir. A spillover event occurs when a human comes into contact with that infected animal through hunting, handling, bushmeat, or environmental contact. This human becomes the index case. And from there, the virus spreads person to person through direct contact with bodily fluids. The table highlights the key risk factors: direct caregiving, without personal protective equipment is one of the most dangerous exposures. Healthcare workers in settings without proper infection control are at extremely high risk. Then you have unsafe burial practices, particularly those involving touch or washing of the deceased, have been documented as major transmission for these events. One critical point is that Ebola is not airborne. It requires direct, close contact with bodily fluids. This means that with proper isolation and protective equipment, transmission can be stopped. The challenge is just implementing these measures quick enough to resource limited environments. The public health impact of Ebola extends far beyond the number of cases and deaths. This chart here shows the overall burden of the 2014-2016 West Africa outbreak. 28,616 total cases, 11,310 deaths, and nearly 900 healthcare workers infected across 10 affected countries. But the burden doesn't stop there. When healthcare systems are overwhelmed by an Ebola outbreak, routine care collapses, people with malaria, HIV, and tuberculosis, also pregnant women seeking potential prenatal care are all affected. Research has shown that indirect deaths from disrupted health services during the 2014-2016 outbreak may have rivaled direct Ebola deaths. The global public health response has evolved significantly. The RVSSV vaccine, now approved as the Ebola, was used in a ring vaccination strategy during the 2018-2020 DRC outbreak and proved highly effective. Monoclonal antibody treatments like imazebeth and ebanga have improved survival rates when administered early. The WHO and CDC deployed rapid response teams for contact tracing and community education, teaching communities about the safe burial practices, and also early symptom recognition has been shown up to significantly reduce this transmission because of this. Despite the advances, major challenges remain, particularly around health equity. Communities in low-income settings still lack access to PPE, trained staff, and advanced treatments. Addressing these systemic inequities is essential to truly controlling Ebola. Let me just close with 5 key takeaways from today's presentation. First, Ebola follows clear epidemiological patterns by person, place, and time, with greatest risk among healthcare workers and caregiving in sub-Saharan Africa. Second, the 2014-2016 West Africa outbreak was largest in history, and nearly 29,000 cases show how rapidly Ebola can become a global emergency. 3, the disease progresses quickly from non-specific, like flu-like symptoms, to multi-organ failures, with cases fatality rates up to 90%. Early detection and isolation are critical. 4, vaccine and treatment advances have improved our ability to respond, but limited resources settings remain highly vulnerable. The 5th one is controlling Ebola requires global cooperation, strong health infrastructure, community engagement, and ongoing research. Knowledge check. True or false questions. I know you do good. Here are my references. Thank you.